Our next speaker, I have to do this, is Dr. Maria Camacho. We'll be talking about urinary incontinence. Dr. Camacho is a faculty member in the Division of Geriatrics and with many years of experience in the area. So let's see what we got here.
Okay, good afternoon, everybody. This is the hardest time of the day to talk about anything. 2 p.m. is the natural tendency to sleep. We are meant to go into a nap. And since Rebecca just finished, I would say that the only thing that's been proven to prevent anything is exercise. So we all should stretch now to stay awake for the next talk, because that's the only true preventive things for anything or everything. It's exercise. So all the rest is trying to. So I'm going to talk about incontinence in old people, and that all starts by saying that it is not normal to lose urine in any quantity or frequency that may be inconvenient for the individual. Actually, for an adult and elderly people are just adults, any amount of leak is inconvenient or, let's say, not normal. So in terms of defining the capacity of the bladder, the first urge to pee may occur after 300 cc's, but the brain, the social convenience, the voluntary actions is able to delay the contraction of the bladder until the volume is much higher than the first urge volume, and that's one of the key elements of the bladder function, that voluntarily the brain can inhibit the involuntary bladder contractions in order to increase the capacity to accommodate social convenience as needed. I have to let you guys know that I gave some slides to Tony few days ago, and since then I worked for this audience a little bit more, and my slides are updated. So you are not really going to find in the paper what I'm saying in the screen. These slides were quite updated, and if anybody wants them, Tony can mail these ones. Many are the same, basically same, but I have put up to date items, especially in the realm of the management and the non-medical management. I will briefly go over this, but I will say very briefly because the next slide will explain it better. There is two counterbalance systems that help the bladder be a container, and one that will help the bladder empty. So the sympathetic system and the cholinergic or parasympathetic system oppose each other in the bladder, causing increase in capacity by the sympathetic and somatic systems. As we said, the bladder in itself has a capacity to contain, and the brain, the somatic nerves, they can increase that capacity, telling the bladder to wait until there is social convenience to void. And then the parasympathetic system helps the contraction of the bladder. And now in the next slide we are going to see how the bladder outlet works. The bladder outlet works in the opposite way. The stimulation for the contraction of the outlet is the alpha adrenergic receptors. So the sympathetic system helps by contracting, by inhibiting the contraction, we help the evacuation, and by stimulating the muscarinic receptors, we help with contraction. So mainly this helps understand the medications. So when we use medications that block muscarinic receptors, we help the bladder increase the capacity. We mainly have these two types of medications that will block here, making the bladder increase capacity, so there is more containment or continence. And we use also medications that block the alpha receptors to facilitate evacuation. So these are the two main receptors that we modified pharmacologically to alter the function of the bladder. In the elderly, the somatic function is also a big determinant of bladder function, because we as people caring for older adults have to deal with people with impaired brain function or impaired memory, and that impairs by means of strokes or dementia the somatic function that will help inhibit the contraction of the bladder, facilitating continence. So yes, people with any sorts of brain damage, mainly dementias or neurogenic bladders, as survivors of stroke, will have trouble containing the urine. For the bladder to function healthy, we have to put together all sorts of requirements, not only the physical function, but an active function, a fit body, and a fit body to reach the toilet, to walk faster enough that the bladder evacuation, but are other physical functions that affect a lot the bladder, such as the bowel function, mainly constipation, and certainly obesity increases the pressure that may increase the tendency to leak, particularly in women. There is behaviors that affect the bladder, such as the amount of fluids we intake and the quality of fluids. Fluids that have too much caffeine and too much citrics will definitely increase the risk of becoming incontinent. But for one hand, because there is a direct xanthine diuretic effect in caffeine beverages, but also because it is a direct irritant in the bladder mucosa that stimulates the contraction of the bladder. Same happens with excess citric fluids, and also with spices are also irritant in the bladder, the same way as in the intestines. Norms and attitudes determine the behavior of the bladder. The ability to have access to the toilet, we said, by having a toilet nearby, by having an able body that helps the individual reach the toilet. The use of medications, and here many medications will affect the bladder, as we said, by either having effect on any of these receptors, the cholinergic receptors, muscarinic, alpha or beta receptors. They all have an effect on the bladder, and particularly the use of diuretics, which is so common in the elderly for treatment of cardiovascular or other conditions. So by filling rapidly the bladder, they overwhelm the capacity of the individual to hold the urine. And we already mentioned that the cortical control of the bladder is so necessary to inhibit the voluntary action or contraction of the bladder evacuating. So now this is just a summary of what we said in the past slide: mobility, dexterity, cognitive motivation to keep the to stay dry, and all the coordination necessary to keep the bladder functioning. What happens with aging? We mentioned some of these aspects already. The ability to cortically postpone voiding meaning the bladder is a little more active per se in the elderly, and it's harder to inhibit the contractions when the capacity of the bladder is reaching a high volume, because the total bladder capacity may be less in the elderly, having more contractility in the muscle. So in general, there may be increased tendency to have a urinary incontinence just by age without any other illnesses. Also, there is more shift in fluids. Why? Because if elderly people have less physical activity, sit a lot, there is a lot of water during the day, sitting in the lower part of the body, particularly in the later part of the day, as people sit or recline or put the legs up, this water is recycled back, shifts volumes, and increases the amount of water that the individual has to urinate at night, having nocturia and the tendency to have leak in the later part of the day. It will be certainly also a contributor that there is more confusion and less mobility in the later part of the day, more fatigue, tiredness, and so on. In terms of who gets urinary incontinence in younger years, let's say 65 to 80, women have much more incidence, prevalence of incontinence, but in the later years, there is also incontinence in men. In the community, the prevalence in different studies may go up to 30%, and in long-term care institutions is 50%. So I think this slide shows one of the great problems of incontinence, and it's one of the determinants or the indicators that people will end up admitted to a long-term care institution because families or care providers cope poorly with the workload that incurs having incontinence. That is one of the reasons that individuals with poor physical or mental functions end up admitted to institutions. It's undiagnosed frequently because we don't ask people, and people will not volunteer the information because, as we said at the very beginning, as grown-ups, we are embarrassed to have any sort of leak accident of urine. So people will not go around volunteering the information that I'm incontinent, even at the doctor's office. So it is very important to educate everybody in the office, in the hospital environment, to inquire and participate in entering the diagnosis of urinary incontinence. Typically in the hospital, you see a lot of people that are wearing depends or diapers, and there is no correlation with the chart. You don't see the diagnosis. So why is this person wearing garments for urine incontinence? Not even the diagnosis in there. So if there is no diagnosis, there is no intervention to modify it or to care about it. We mentioned already some of the risk factors: constipation, chronic cough, obesity, and in women, obstetric complication, obstetric injury to the lower urinary tract is very important, causing bladder drop that will end up changing the anatomy and resulting in leak. So it's great risk factor for stress incontinence in women. And we mentioned already that the neurologic complications of elderly, either stroke, dementias, or any other neurologic diseases may result in neurogenic bladders. and as well as other medical illnesses that have nothing to do with the nervous system, but for example, pulmonary, cardiovascular conditions, increased intra-abdominal pressure by means of heart failure, by means of COPD, cough, etc., that will result in the increased risk of leakage. All put together, there is many conditions. Parkinson's always end up having autonomic dysfunction that will increase the risk of bladder dysfunction, bowel dysfunction. Spinal stenosis, very frequent as you grow older. So there is many circumstances. The increased urine output by uncontrolled sugar, the increased urine output by hypercalcemia. Here, when we see these circumstances, is also the volume of water retention, but also the use of medications for get rid of the volume, the diuretics that will affect. Certainly, alcohol will affect the mobility, the dexterity, the coordination, the motivation, the social support, and also will cause neuropathy. So it's another big one determinant of decreasing autonomic function. Now we're going to see the types of urinary incontinence. I will pay attention to transient because wherever it's transient, we have to modify it. We should be able to modify it. So it's very important to look at that. Transient incontinence may be up to 1/3 of the people we see with incontinence, and 1/2 of the people we see in the hospital may have a factor that we can modify. So let's see what are those factors that can be modified. Of course, in the hospital setting, frequently delirium. If somebody is confused, no awareness, no motivation, no capacity to properly evacuate. Infections. In general, infections or infections in the bladder, but urinary tract infections that could cause leak if they are symptomatic. We don't look systematically for urine infections in people with incontinence because the association is low, meaning you look at the urine, you look at a urine sample, and if there is bacteria but there is no symptoms, you give antibiotics and the incontinence will not improve. So it may be a bystander. We try to do management of estrogen deficiency in women because the atrophy, the shortening of the urethra and the flattening of the mucosas will help a stress leak. So by using estrogens that can be topical estrogens, we can really modify urethritis and stress incontinence. Even though the medication may be topical, lots of women get systemic effects and may not continue using. If they start having breast swelling or discomfort, they stop the use of topical estrogens. Medications, we said, like if people don't necessarily need high doses of diuretics, or if they are having any anticholinergic medication that can be modified using alternative drugs, we can prevent this. And certainly we focus a lot in mobility because sometimes the individual has a normal urinary tract but just slow legs, slow mobility to reach the toilet. So physical therapy and so forth. And definitely very, very frequent cause in the elderly of urine infections, urine incontinence is chronic constipation. In terms of urge incontinence or overactive bladder, we have the following signs and symptoms. Increase in frequency. So it can be day and night, and urgency. The problem here is the individual is able to feel the signal that the bladder is telling that you need to pee, but you cannot reach the toilet timely because the timing between urge and evacuation does not allow to increase capacity, and that lag of time between the bladder urge and the opening of the outlet is too short and does not give enough time to contain the leakage. What can we do to know if the problem is in the outlet or the problem is in the bladder capacity? So a very simple means to check is to check the post-void residual, meaning is the individual able to completely empty the bladder or not? So in both men and women this can happen, but more commonly in neurogenic bladder problems or in male problems, we have elevated post-void residuals, meaning after a voluntary evacuation, there is still urine in the bladder. How much? More than 150 cc's. So the residual volume should be less than 150 cc's. It helps differentiate if there is Detrusor disease or outlet disease, outlet obstruction. So we can do this in any office setting, but if there is doubt and you are not sure what kind of incontinence the individual has, you can refer the individual to a urologist or the urogynecologist. So for females nowadays there are many gynecologists that do only bladder and continence. Like here at UTMB we have a continence clinic where they have inside in the clinic on the individual clinic visit the ability to do urodynamics and check the volume capacity of the urine, the evacuation, the post-void residual, all that in the setting of the clinic on a site visit. So it is important always, particularly in men, because it's more frequent in men, to rule out retention by physical exam, by ultrasound, or by putting a bladder tube in after the individual finished urinating and checking if there is still urine in the bladder that is not being completely evacuated. In terms of female, stress incontinence is the second most common type of bladder incontinence in women. The overactive bladder is more common, even in women with gynecology conditions, even in women with drop bladders and even with uterine prolapse. Still, there can be overactive bladder on top of it. So by means of investigating, we can, because if we just think it's a stress, the individual may not be cured or improved by means of only using modifiers for stress incontinence. So, stress incontinence is mainly the failure of the sphincter or the bladder outlet to hold the urine in the bladder when the abdominal pressure increases. So by coughing, standing, sneezing, laughing, the bladder will start emptying involuntarily, causing usually small amounts of leak rather than massive leak, but it may be frequent small leakage instead of large involuntary incontinence. So it may be genuine stress incontinence by impaired pelvic support or a trauma to the sphincter, by scarring due to surgery, like in men, or this is the type of incontinence that may occur after prostate surgery in men. Transurethral surgery are the most common type of incontinence with obstetric trauma. The overflow incontinence occurs when we have increased post-void residuals. If there is continuous high volume in the bladder, the Detrusor, the muscle, becomes so unaware of the capacity. The capacity goes beyond those 600 cc's that we mentioned at the beginning of the talk, and the bladder loses the capacity to recognize fullness. But it's limited because it cannot increase more. The muscle is stretched to maximal, so as it cannot stretch ever more, will start leaking. So this will be, let's say, fortunately, one of the things that may happen. The second thing that may happen in men is that if there is severe outlet obstruction with bad prostate problem, the individual may go to very large capacities, like around 1,000 or even a little more than 1,000 cc's, and being totally unable to pee. This becomes a medical emergency, big abdominal distension, pain, and in individuals that are cognitively unaware, we have to be, as clinicians, the ones that recognize even individuals with good cognitive function. I find, and here's, for example, our clinician from the ACE unit, Bronia. Even individuals that are not demented, because this occurs slowly over time, the individual becomes very unaware, that's not evacuating often. And if you don't examine properly the abdomen, recognizing that there is a bladder globe, you may overlook it for quite a while before you recognize that the individual has gone into quite urinary retention. So the symptoms of urinary retention: dribbling, weak stream, very small volumes of urine over time, increasing frequency and nocturia, which is kind of what we call prostatism, or typical of men with outlet obstruction. Outlet obstruction can occur in women, yes, usually by irritation, like after a woman has had a bladder tube by means of surgery, hospital admission, and so forth. You remove the tube, and there is so much irritation in the urinary tract that it becomes too contracted and it can't evacuate. That is much more frequent or more often seen in men. The causes: benign prostatic hypertrophy, prostate cancer, urethral strictures, like after intervention, or traumatic strictures. That these are modifiable causes, particularly if they are determined and diagnosed early. And as we mentioned, in women are usually irritants: infection, previous surgery, big drop in the bladder, or the use of catheters in the past. Common questions that we can ask to find out what's going on: frequency, volume, medications used, how much people drink. We said we can measure the post-void residual volumes over 150 cc, suggest that there is outlet obstruction and is starting to have urinary retention. Going back, urinary retention can end up causing renal failure, so it's so important to find these bladder globes. What can we measure? Make sure the individual has not is not having renal dysfunction by means of having prolonged urinary obstruction. We said that urine cultures we don't do systematically. Once you If it is new onset urinary incontinence, you rule out an infection, but if it's chronic urinary incontinence, that we said the bacteria may be bystanders and not the cause. So what can we do in terms of management? We can modify all these factors that we mentioned before. So we will start by mentioning that we start by behavioral interventions, then medications, then surgery if necessary. So first, and we need to have goals. What could be the goal? For example, if an individual gets up at night 5-6 times, interfering with rest and good sleep, your goal will be to decrease the number of times that the individual have to get up at night to have good quality of life, good sleep, better day functioning. So you have to set up some goals to stay, the goal simply to stay dry or to reduce frequency. We have to do behavioral interventions like limiting the fluid intake, always making sure that there is no constipation, and consider testing if the common causes and the common empirical therapies that you have done fail. Think more, investigate more, try and send people to the specialist so they get a proper diagnosis. So with first behavioral intervention, limit the volume and the kind of things you drink. So we said it used to be in the past that people didn't use these huge amounts of fluid. Like, I agree with Mayor Bloomberg in limiting the intake of sodas. Sodas in itself cause bladder trouble, coffee in itself, caffeine, tea. So we here in America do grande, very large volumes, and also drink things other than water itself. So everything else other than water can have in it irritants. So we have to go back to small, nice cups. So the second behavioral intervention is keep the bladder empty. So go to the toilet, empty the bladder before the bladder overflows. So that will be one means to keep the bladder empty, increasing the voluntary travels to the toilet and recording how many times and how often, and then modifying the bladder capacity until the individual can reduce the number of leak events. So if the individual is cognitively impaired, all these interventions need to be completed by the care provider. So you need to prompt the travels to the toilet. You need to reduce the volumes of intake, and you need training and motivation that the individual cannot do alone. In terms of modifying the bladder storage with medications, we're going to look at which medications we commonly use. These are the most commonly used medications, and they cause a lot of side effects. They can increase so much the capacity of the bladder that can cause urinary retention. They can reduce perspiration. They can cause dry mouth. They can alter vision or increase the risk of glaucoma, and ultimately in the very old, we see it often can cause confusion. Also, they work in the heart. They can cause tachycardia. So we see all here different medications depending on what type of muscarinic receptor they affect, can cause all these side effects. So we use these medications, but either we stop them or the individuals stop them as they get side effects. Individuals may be unaware of the medication causing this side effect, but they definitely notice dry mouth, they definitely notice changes in the eyes, but we have to be aware also when we see individuals with new delirium, change in mental function, are they taking one of these anticholinergic medications that may be the cause of confusion? See, other medications such as beta beta agonists also have been used, and they are not being used in the US like they are used in Europe. They are more frequently, they reduce the number of visits to the toilet and also increase the capacity of the bladder. I think this slide that did not show was talking about the selectivity of receptors. In general, the older medications like Detrusor have less selectivity, and the newer, more expensive medications have more selectivity, but yet even the new and expensive medications, they all have muscarinic side effects. The management of stress incontinence, we have exercises. We have that need a lot of cooperation, understanding, and interest for the women to participate. The patient needs to understand the anatomy to learn what muscles in the lower part of the body, in the perineal area, she needs to contract to stop the leakage. But usually the nurse clinicians that teach women to do the Kegel exercises, teach women to put their fingers in the vagina and near the urethra to see if they can contract and cause continence by increasing the abdominal pressure and contracting down below. But it requires motivation, participation, self-interest, but they have proven to work, these exercises, because muscles, like any other type of exercise, these are voluntary skeletal muscles that can gain strength by doing the exercises, but then you need the individual participation and the doing repeated sets of contractions during the day, so it requires a lot of interest from the patient point of view. The other thing we do for stress, the topical estrogens that we mentioned before to reduce stress, the risk of urine infections, the risk of urethritis. And then if this all fails, we have to consider surgical interventions. So if we talk about stress incontinence, surgery has the highest rate of cure for these problems, and the approach depends on the type of problem. Is there also prolapse? Is there need to do hysterectomy at the same time, or would they need to pull up the uterus alone, or there is only anterior wall damage and prolapse of the bladder, and so forth. So the different approaches include different interventions. Nowadays, when we see this, we see that human beings have more tendency to have stress leakage because of the postural, the posture of the Homo sapiens, right? Because there is more pressure on the bladder, because half of the body weight has pressure in the lower part of the body. Nowadays, because of increased weight, there is much more pressure on the lower part of the body and much more volume retention, so we're going to see more and more of stress incontinence in all sorts of individuals. These are the types of interventions the surgeons do, and you see now these ads in the television. There is several different companies that produce different items that the surgeons can use to lift up and hold up the bladder outlet. So these are the famous slings, so they can be to be transpubic or transobturator. They have to go with the needle across all the muscles that cover the pelvic outlet here and go over the abdominal muscles, securing the end on the abdominal wall on each side and pulling it up. What are the problems that these surgeries had in the past? And I was saying more in the past that these surgeons used to tight it too much. So what can happen, that it can be too tight and the individual, let's say the female, may go into urinary retention. But this being pulled too hard, it may cause a stricture or closure. And they will have to go do a release, a second surgical intervention to leave it loose. Nowadays, surgeons are very aware of this complication, and there is much less frequent occurrence of overdoing it. And the different devices are becoming smaller and smaller and more practical, so these operations can be done in ambulatory setting. It's nowadays almost an office procedure. It's becoming more and more practical. And when I say and show that this is easy, practical, and not so major, is for us to be aware that you can send for this type of surgeries very old women. Why? Because they are the ones that have more incidence and more need, because they are not going to be able to do a lot of the other interventions that even younger women can do, and that this is not, in terms of surgical risk, a very major surgery. It requires a lot of skill and ability from the surgeon, but in terms of the surgical risk for the patient, it does not require a lot of surgical risk or blood loss or so. So you can send to have success surgery very old women that have even cardiovascular disease. So now this is a table showing cure rates of different approaches with these surgical interventions, and the cure rate can be as high as 90%. So, and the complications in the later studies are less and less. So we encourage people to try and send patients to be evaluated and consider surgeries. Some of my tables did not show, but okay. In terms of men and overflow, again, we have to consider surgical treatment, particularly sooner than later. So that's why it's important to have good evaluation. The type of medications that we can use, as we were saying, for bladder outlet obstruction, from the old to the new, alpha blockers, always with the precaution that individuals can have low blood pressure, short-acting, long-acting, newer and older, they all can have side effects in terms of dropping the blood pressure. They have similar efficacy, just different side effect profile. In men with bladder outlet obstruction that cannot tolerate alpha blockers, we can consider also to block testosterone to reduce the prostate size to facilitate the bladder outlet. We always have to look for the risk of prostate cancer if we are going to use this, because we may mask by blunting the raise in PSA when we start finasteride. In terms of Detrusor underactivity, in the past, at least I did, use bethanechol and medications to improve bladder contraction. We use less and less often these medications. So unfortunately, the best intervention for Detrusor underactivity, when the bladder capacity is gone too high and does not contract, we need to help it by doing intermittent clean catheterizations. This week I saw in the clinic a man, 95-year-old, and for many years he has been doing this himself. And he says it takes 30 minutes for him to do it. But he's managing at home, he doesn't get infections, he's doing the intermittent catheterizations. If we don't encourage people to do this, they end up with urinary retention, with dysfunction, with infections, with hospital admissions. So it's very important to avoid ongoing bladder outlet obstruction. In conclusion, there is importance in looking for the problem, proper diagnosis, starting with conservative management, moving into medications if needed, send referrals to the surgeons. I think I didn't talk much here about the neurostimulators, but I had a picture. Oh my God, that's a picture that didn't show. The neurostimulator is a device that can be put under the skin in the lumbar area, stimulating the bladder. There is tests that can be done in the office to see if the individual will respond, and that's the ultimate intervention if the individual has failed medications or is not a candidate for surgery. And these stimulators, we do them here at UTMB, and they can be implanted, they can be adjusted over time to facilitate the urine, to reduce the involuntary bladder contractions and facilitating staying dry. All right, I think that may be the slide that did not show. I had a photograph of an individual with the neurostimulator. Thank you. Do you have any questions? You see, is this sleep time?
All right, thank you, Marie.
Thank you.